Pericardial effusions presents with muffled heart sounds and dullness, percussion around the apex with reduced, because why is the QRS voltage on EKG is going to be, because that fluid in there is going to stop the electrical impulses from getting to the skin. Or electrical alternans if a large effusion is present. Echo is diagnostic. Pericardocentesis aids in diagnosis causes of the effusions. You can get culture, cytology. Adenosine diaminase activity, ADA, is used for identification for what? What is this going to be? This is going to tie into what? Our ID section. Tubercular pericarditis, TB pericarditis will have an elevated ADA. Asymptomatic effusion does not resolve in 3 months if pericardocentesis should be performed. All right, let's get a clinical scenario right here. Is a 67-year-old male with sudden chest pain, shortness of breath, and blood pressure of 67/42. So the MAP is low. They have negative cardiac cath 2 weeks ago. So what's going on? So they had a negative cardiac cath 2 weeks ago. Now they have sudden chest pain, shortness of breath, and a low blood pressure. This blood pressure is not sustainable. This patient will die unless you do an intervention. So what do we have? What do we got here? Now let's look at this echo. See that fluid around there? See that fluid collecting around the heart, and look at the heart. There's a space between the visceral and the parietal pericardium. So we have, let's go back to it. We're going to have right atrial and ventricle collapse. Collapsing of the right atrial and ventricle during systole and right ventricle during diastole. Systole and diastole. Right ventricle is collapsing during diastole, and then collapse right atrium during systole. Inferior vena cava plethora, dilation and lack of collapse of the inferior vena cava with respiration, indicating elevated venous pressure. Respiratory variation in inflow velocities, exaggerated changes in blood flow velocities across the mitral and tricuspid valves with respiration, another side of tamponade. Cardiac tamponade is due to increased interpericardial pressure from accumulation of pericardial fluid and presents with dyspnea, tachycardia, pericardial pulses, paradoxal pulses. We beat this one up. I can't even say it, we beat it up so much. Elevated JVT, distant heart sounds, hemodynamic instability, and hypotension. We got the Beck's triad, remember it? Increased JVD, hypotension, and muffled heart sounds, causes previous pericarditis. You have viral idiopathic anemia, malignancy can be in there, cardiac trauma, or myocardial perforation during catheter or pacemaker replacement. Okay, pacemakers, when do we place them? Now the whole goal is to prevent the heart from going too slow or too fast. We'll talk about this, in sinus node dysfunction. So we place them in symptomatic bradycardia, which makes sense. We've already talked about the 3rd degree block and the AV blocks and Mobus type 2 AV blocks with QRS greater than 120 milliseconds. Symptomatic type 2 degree AV block, Mobus type 1 or 2. That's symptomatic. Severe systolic heart failure with a left ventricle ejection fraction less than 35%, left bundle branch block, or and NIH and New York Heart Association class 2 or greater, despite optimal guideline-directed therapy for 90 days. So remember, we have that stub period where someone, if they needed to, they would wear a special type of external device that could shock them. The senses that their heart is in a dysrhythmia, and it can shock them. Remember, the goal is to keep this patient in the best sinus rhythm as they can. Notice sinus dysfunction gets worse with aging and fibrosis. And there's different types of devices that can be placed. There's a single lead in the right ventricle. You can have a dual chamber, which is going to be the right atrium and right ventricle, can sense electrical activity in the right atrium and right ventricle, senses AV block, and can deliver electrical stimulus to the RV by bypassing the block pathway. Also senses when a heart rate is lower than programming. This is going to be sinus node dysfunction. You don't need to know these, but you need to be able to understand this lingo because your patients are going to know it, because somebody's going to explain it, and they may ask you a question and you want to sit there and go, I don't know. and then call up ChatGPT, you have to know what you're doing, and you have to have a base of knowledge to be able to correspond. So that's why we get into some of these cardiac things. Is yes, it helps you with boards. Yes, it helps you, but it also helps you take care of your patients. Cardiac resynchronization therapy, CRT. This is the same. This is going to be for. We'll talk about this a little bit more when we're going to synchronize. All right, here we go. Learning by questions. Which of the following is the most appropriate step in management? What is the following most okay? So we have this concurrent medical therapy, reassess left ventricle function in 6 months. That's a long time. Refer for coronary angiography. Refer for primary prevention in implantable cardioverter defibrillator, ICD placement. Add amiodarone. And remember, amiodarone's been in a lot of our things for arrhythmia prophylaxis. Schedule for cardiac resynchronization therapy, CRT, without defibrillator. All right, let's take a look. Let's go through the question. 62-year-old man with history of anterior myocardial infarction 6 years ago. So 6 years ago, hypertension and well-controlled diabetes. So looks like he's doing okay. He had a heart attack, he has hypertension, and we don't know if it's controlled or not. And he has well-controlled diabetes for follow-up. He's asymptomatic, but his echocardiogram shows a left ventricle ejection fraction of 28%. He's on optimal guideline-directed medical therapy for heart failure. We kind of discussed this, didn't we? Including a beta blocker, ACE inhibitor, and mineralocorticoid receptor antagonist. He has no history of syncope or documented ventricular arrhythmias. Okay, so what are we going to do? What are we going to do? Now, just think about this. We're going to refer for primary prevention implantable cardioverter defibrillator. Remember, our ejection fraction of 28%, less than 35. So patients with ischemic cardiomyopathy with left ventricle ejection fraction less than 30, 35 in New York Heart Association class 2 or 3 symptoms despite optimal medical therapy. Now, in this case, he says he's asymptomatic. So probably this is a better way to write this is if he said that he had a little bit of symptoms like shortness of breath. Anti-tachycardia pacing detects life-threatening tachyarrhythmia and gives electrical currents to interrupt a dysfunctional electrical pathway. Now let's look more about this. Now, this is a question. So what can you do is how do you know what device a patient has? So say for a patient comes in, they can't remember what device they had. So what can you do? Well, see if they have the identification card. Hopefully they have it. A lot of times they lose it. But what's the trick? So get a chest x-ray. In the chest x-ray, you're going to see the device. In that device, there's certain shapes that require the manufacturers will have certain shapes. And what do? There's an app for us. Did you know there's an app for that? That you can go and you can find a device. I'll also tell you another trick. What if the patient, you don't know who the patient is? If you get the chest x-ray and you find out the device, you get whoever the device is owned by, whoever the manufacturers, come and have them interrogate that device. Guess what? You know everything about that patient. You know when they got that device, where they got that device, what their name is, even gives you everything you need to know about that patient. So that's kind of a sneaky trick, probably not legal, to find out the patient's name and information. Maybe if you have a patient that's obtunded, you don't know. If you get the chest x-ray, you get the app. Once you know what the device type is, you get the device interrogated. It will give you everything you need to know. You get the pacemaker ID and the cardiac management device finder, and then you can get the device interrogation. It's going to give you everything. The event log, lead function, programming, battery life. Now, this is going to be a question. Question. If infected, what do you do? If these devices get infected, what do you need to do? And that's going to be your board question. And your real world question. You got to remove the device. What if it just says there's an infection in the pocket? It doesn't matter. Remove the device. Infection anywhere, it has to remove the device. So which the ones that we can worry about? Staph aureus and fungus. Now see right here, in this x-ray right here, this is a specific manufacturer. We're not going to say brand names here. I say brand names, but this is a specific manufacturer. See that right there? Easy to look up. There's apps for it. You can find stuff online. Even the manufacturers have stuff on there that will tell you what their devices are. All right, implantable cardioverter defibrillator for sudden cardiac death. So what is this? It's a combined ICD and cardiac resynchronization therapy device if patient meets criteria for both. So when is implanted? So we're going to go first on the implantable cardioverter defibrillator. It's going to be a New York Heart Association class 2 or 3 while in optimal medical therapy. Expected survival greater than 1 year. These things cost money. That's why we have to make sure the survival is greater than 1 year. Ischemic or non-ischemic cardiomyopathy with a left ventricle ejection fraction less than equal to 35%. MI greater than or equal to 40 days ago and left ventricle ejection fraction less than or equal to 30%. History of hemodynamic significant ventricular arrhythmia, syncope or neurosyncope or cardiac arrest. Now let's come back. This is the biventricular pacemaker resynchronization therapy. Here we go is combination of ICD, CRT device if patient meets criteria for both. So what are the criteria? So this is a little bit sicker. They're a New York Heart Association class 3 or 4 while receiving optimal therapy, sinus arrhythmia, QRS greater than 120 milliseconds, and left ventricle ejection fraction less than or equal to 35%. If you have class 2 symptoms, mild symptoms, sinus arrhythmia with a left ventricle ejection fraction less than or equal to 30% and a QRS greater than or equal to 150 milliseconds in left bundle branch block. So CRT is associated with a 50% reduction in cardiac resynchronization therapy and mortality from progressive heart failure. Let's talk more about cardiac resynchronization therapy, CRT. This is simultaneous pacing of both the ventricles, the biventricle pacing, or one ventricle in patients with a bundle branch block. So you're making the heart equal on both sides. You're creating a symmetry. Improves left ventricle performance by restoring normal sequence of ventricle depolarization and contraction. Improve exercise tolerance, reduce need for hospitalization, and decrease overall mortality. Those are the things we want. We want them out of the hospital, we want them living longer, and we want them to be able to exercise. These are all the 3 things we want. These are how we're going to beat the horsemen of the apocalypse, is we have improved exercise, decrease hospitalization, decrease mortality. Consequences of a prolonged QRS. Now let's talk about this. Now we're in the heart side, right? Now let's go over to another discipline. Let's go to the critical care side. And what's something that somebody can take that can prolong their QRS? And we specifically look at QRS. TCA overdose. TCA overdose. So we're trying to tie things together. So what's the treatment for TCA overdose? Bicarbonate drip. Remember, everything kind of flows together. So we have to work with our different systems. Patients don't just come in and say, hey, I have a cardiac problem. I have a multiple chest cardiac problem, and I don't have any lung problems. They're going to have all sorts of problems. Some patients, every system is broken. There is not a system that's not broken. These is the normal world, is you're going to have everything broken, and you're just trying to figure out what is broken less and what is broken more, and what do I fix the broken more stuff? What do I do? Do we do goals of care? What do we do? So remember, nothing comes in isolation in the real world. And in boards, it's nice, they have a little isolation. You can say this is just a heart problem. We have a lot of problems. Consequences of prolonged QRS. Delayed ventricle activation, delayed lateral wall contraction, disorganized ventricle contraction, decreased pumping efficiency. So if we're not being contracting on time when we need to, we're going to have decreased pumping efficiency. Reduction in diastolic filling times because everything's in disarray, and so you're not going to get the blood back in the heart to fill properly. You're not going to contract properly. Prolongation in duration of mitral regurgitation. So all these things can happen from prolonged QRS. Okay, so the patient goes and gets an AICD placed, then has a sudden swelling in his face, upper body and arms. So upper body and arms with hoarseness, headaches, and chest pain. So they did the right thing. And they placed an automatic implantable cardioverter defibrillator. They followed through all the stuff. They did everything they're supposed to do. So what happened? What happened? One of the side effects. That's why we don't just place these in everybody. When somebody walking on the street, we place it. SVC syndrome. After recent AICD placement, thrombosis and occlusion around the leads to dyspnea, head fullness, facial arm swelling, worsening with bending and or laying down. May develop syncope or pre-syncope. So we've done the right thing, and they have what's called SEC syndrome. Just think about it. The ICD is going through the heart and has thrombosis and occlusion around the leads, causing SVC syndrome. All right, another clinical scenario. 32-year-old male with no past medical history, so should be pretty healthy right now. No past medical history, presents with rapid heartbeat, lightheadedness, and chest pain. What do we got? What are we looking here? Oh. Now this isn't blood here. I'm going to show you this right here. I was so excited as a resident that I got this perfect EKG, and we'll talk about the disease. I spilled some spaghetti on her. I'm Italian, so I spilled some of my spaghetti on my perfect EKG. So it's still sitting there forever. But what do we have here? WPW. What do we got? The PR interval is shortened, less than 0.12 seconds, and the QRS complex is widened. So what's this right here? What's that word right there? What's that thing right there? This is a delta wave. And like I said, I was so excited when I got this that I spilled some spaghetti that I was eating on my lunch on this. I'm telling you, we eat spaghetti and we spill it, okay? Get over it. WPW syndrome. What is this? You have the bypass pathway. The bundle of Kent, a discrete, apparent conduction pathway that conducts the atrial and ventricles and can be right or left-sided. You have PVC depolarization with the bundle of Kent causing two things on EKG. The PR interval is shortened. PR is less than 0.12 seconds. The QRS complex is widened more than 0.1 second. Unlike bundle branch block, in which the QRS complex is widened because of the delayed ventricle activation, and WPW is widened because of premature activation. All right, we've got a visual of it right here. Okay, see the delta wave right here? This is the delta wave. And the PR interval, P to R is shortened, P to R. Here, P to R. So right here, P to R ratio. I'm sorry, I drew that wrong. P to R ratio interval is small, less than 120 milliseconds. So right here, this is our accessory pathway that we're getting, accessory, outside the normal pathway. So instead of the sinus node going through the AV node down to the bundle branches, the right bundle branch, we have an accessory pathway. Short PR interval, so P, let me do that again because I kind of messed it up. P to R is shortened in a widened QRS complex. We have that delta wave.